All right, so that's the team, and you'll be meeting more people as we go along. And I'm Mark, and we're going to keep this fairly informal, and hopefully we'll get into some good discussions back and forth. And we're small and intimate, which is quite cool, so hopefully we get to know each other as the day goes on. Okay, so I guess I would characterize myself as a rebel. And so a lot of things I say are provocative, and so I'll be open to having some fun, perhaps disagreeing. But I guess what I would say is that I'm frustrated because Lori and I started out with masters in Johnson, and we were specialized in sex therapy and sex research. And we decided to open up inpatient programs for trauma with Dr. Masters because we were interested in the effects of rape and incest. And at that time I was feeling really frustrated because having worked in inpatient hospitals, well over 95% of the women that presented had been raped or molested. And at that time, the psychiatrist in charge would say, don't ever mention anything about rape or incest because the patient will decompensate and become psychotic. Either were borderline meant to them that they were going to become psychotic. You don't want to make the patient worse. And literally, you weren't allowed to. And I said, you're all crazy. I mean, if somebody comes in with rape, they need to be able to talk about it. So with Dr. Masters' power and strength, we were able to open up inpatient programs. We had one in New Orleans, we had one in St. Louis, we had one in Kansas City, and Los Angeles. And there were 25-bed units that were specialized in trauma and dissociative disorder. And at that time, we didn't know much about how to treat it. Christine Courtois had just written the book, Healing the Incest Wound, and we got to be good friends with her. And Bessel van der Kolk was doing the work with veterans, and we got to be friends with him. And so that was the background. And I started really studying the World War I literature on abreaction. And that was where we got schooled. So anyway, we did that work, and what we found was that if we did trauma work with people and had them talk about what happened to them, they got a lot better. And patients who came in who were borderline, they became less borderline. They're on the Gunderson measure of borderline personality disorder, whatever the score was, it would decrease rather than increase. And that was pretty dramatic. And yet, we realized that what we're doing was necessary but not sufficient. And there are probably two factors there. One was that a lot of the clients had addiction, chemical dependency, eating disorder, workaholism, sex addiction. And each of those subspecialties required a certain expertise. And so in addition to the trauma, you had to know those subspecialty expertise. And the other thing that was a dilemma was that we recognized that most of the people had what we call an intimacy disorder. And it meant that they felt alone even with people. They had a major sense of disconnection. And so even when we did the trauma work, we were noting that there was this incredible sense of aloneness. And so I was really interested in what I called intimacy disorder at the time, and began to dive into sort of understanding that. Lee and I are going to start the afternoon by talking about our understanding of intimacy disorder and what to do about it. So it's that background which I'm going to be talking about this. I'm going to walk you through the last sort of 40 years of what we've learned. So what this talk is about is addiction. And I'm angry that we have so much relapse. Lori and I moved from the inpatient programs to opening a program in St. Louis for eating disorders. And we learned a ton about treating eating disorder over a 15-year period, but a lot of people relapsed. And as Sc.D programs, a lot of people relapse, and it's frustrating. So we've become really focused on studying relapse. What we did is we set up a program. We would call the patient once a month after they left and do a detailed interview with them. And we had really good compliance and could look at what happened for the year after they left us and studied that closely. And so in this present incarnation, just to introduce ourselves, what we decided to do was move to Monterey because it's heaven. And we deserve it. And then we decided to open up a partial hospitalization program because what was happening was the clients would leave, they'd be incredibly changed in a positive way, but they'd go back to their home environment, and the impact of being in such a loving, nurturing environment to their home environment was just too great, and they would crash and burn. And so the idea was if we could do partial hospitalization, then they would have the ability to be able to live in the real world, and it wouldn't be such a shock. And they would have some time of their own to slip and fall, and we could hold them during that period of time. So our program is 8 in the morning until 2 in the afternoon, and we have 3 tracks, one for eating disorder, one for chemical dependency, and one for post-traumatic stress. In the post-traumatic stress, we see a lot of PTSD from the military, because we have a TRICARE contract. And then we see in the eating disorder, we're seeing traditional eating disorder clients. And then the Sc.D track, we have chemical dependency. And why we decided to go that way was that so many people had, one thing would go down and one would come up. So chemical dependency go down, eating disorder come up. Eating disorder go down, chemical dependency come up. And the idea of going to sequential treatment center, one for this, one for trauma, one for eating disorder, one for Sc.D, and one for sex addiction, seemed nuts. And so having these tracks, we can begin to hit all of these at the same time because they usually have the same origins. And it turned out to be a really intelligent thing to do because the therapeutic community is sort of better than anything we put together before this, which was that we're interested in relapse and why clients relapse. And that's what I want to talk about this morning. Why is it that we have so much relapse? And my premise is 2 things. One is it's natural in the sense that you can do an intensive treatment, but it's going to take some time for all that to teach somebody to percolate. So if you do an intensive treatment for eating disorder, it may be a couple years before they're able to utilize all the tools that you're giving them and get better. So to expect people to be cured at the end of a period of time, addiction is a chronic illness, and it does take time for a lot of these things to gel. But the second thing is, I don't think treatments are adequate. And so what I want to do is I want to highlight what I think is missing from traditional programs. So I start out with this, which is this interesting phenomenon, which is that repeated administration of any drug leads to the brain compensating by suppressing the natural arousal. So if you take a sleeping pill, whatever systems in your brain that put you to sleep stop working, and you become dependent on the sleeping pill to sleep. And so if you get off the sleeping pill, you ain't going to be able to sleep. So that's kind of a disadvantage. So you need the drug to feel normal. If a chemical is used with regularity, the brain's response is to facilitate the opposing state. There's a natural tendency towards homeostasis. And so for every action, there's a reaction. The brain is designed to return the system to its homeostatic set point, counteracting the pleasure. So for example, if you have a love affair and you give somebody an fMRI, it's identical to if they're taking cocaine. So if you look in the nucleus accumbens, there's a rush of dopamine, person feels lots of pleasure, and the brain doesn't know the difference between falling in love and taking a hit of cocaine, right? You could have told me that. And on the other hand, if you have a heartbreak, it's going to be like coming off, and if you give it some time, the brain will come back to its natural state, thank God. So what's the point? The point is that from the brain's point of view, there is tolerance that develops, and you need more and more to get the same hit, and that the drug is going to lose its effect over a period of time in some way. So one reason why we have so much relapse is because, a person gets a lot of pleasure from cocaine for a while, and they need more and more to get the same pleasure, but that after a while, it's not going to give the same pleasure. So that'll be a problem. And so the person wants to go back and get that experience again. And then two, that this is from Cove. He said the calming or stimulating effect which the addict obtains from the drug is impermanent. That's the point. Whatever the chemical nature of the substance that is employed, no psychic structure is built. And what that means is that avoidance through drugs or any addiction doesn't really cause much growth, because it's as we all know, it's basically the person is avoiding something that would cause them to grow in some way. So he says it's as if the person with a wide open gastric fistula were trying to still his hunger through eating. He may obtain pleasure and taste sensations by his frantic ingestion of food, but since the food does not enter the part of the digestive system where it's absorbed into the organism, he continues to starve. So it's non-nutritious kind of food. And I like this sentence. The deficit in self remains. The deficit in self remains. Now, to me, that's the ticket. And what I mean by that is that I believe that the reason why a lot of treatment programs have failed is because the first goal is sobriety and getting under control of out of control behavior, and that's good stuff. And that's sort of stage one of treatment. But stage two of treatment is reconstructing the self system. Because when you do not have a cohesive sense of self, the feeling inside is emptiness and aloneness. So our clients say, I feel like I'm an imposter. I feel like I'm alone. I feel like I've been alone all my life. And even when I'm with people, I feel alone, right? A disconnection, a profound disconnection. And so, I'm a recovering cognitive behavioral therapist. So I said, okay, let's help them get a sense of self. Let's, name 3 colors you like. And what's your favorite animal? See, you have a sense of self. And, that was worthless. So I began to wonder, how can you develop a self? And so, where do you go? Back to Winnicott and Kohut, right? So I went back and reread Winnicott and Kohut, the self-psychology. And, it's all there. Everything you need to know is there. It's just that somehow, that's old stuff, so we don't reread it. And when you reread it, what you realize is that what happens since then is this new phenomenon of understanding dissociation. And so, built upon the Kohut and Winnicott stuff is our newfound understanding of dissociation. We knew more about dissociation in 1900 with Pierre Genet than we do in the 1990s. So, oftentimes, a therapist will say, oh, I do trauma work. And I'll say, oh, tell me about it. And they'll say, well, I took a course in EMDR. And truth be told, a course in EMDR is not really trauma work. EMDR is a tool, but it's not trauma work. There's so much to trauma work. And that's really what this lecture is going to be about, is trying to lay the pieces about it. Now, what happens is that as the individual is growing, things happen that impact them. And so our most recent developmental data is showing us that that there are sequential developmental effects upon an individual. So it's kind of like a domino. So if you say to someone, why do you think you're an opiate addict? They probably should say back, that's a stupid question. Okay? Because everything in your life affects you. And so the first thing happens, which then affects the second thing happens, which affects the third thing that happens. And so there are a set of developmental sequential events that occur in a person's life, and each one of them contribute. So what we're looking at is the trajectory for the development of an eating disorder. So what is the trajectory for the development of an anorexia? And the answer is there's about 10 trajectories that we were able to identify at Castlewood. And the treatment is really different from one trajectory for anorexia than the 10th trajectory for anorexia. So instead of saying what's the cause of the treatment of anorexia, we ought to be saying what are the 10 trajectories of anorexia and what are the interventions for those trajectories. That make sense to people? Okay. So, and eating disorder is really different than chemical dependency. And it's really different than sex addiction. So it's hard for one clinician to get an expertise in all of these things. And so it's helpful to have a team of people where each one, knows things that the others don't know in some way. What happens is that around adolescence, a person, if they've been allowed to connect and then separate and individuate, is beginning to coalesce a sense of who they are in relation to the world and other people. And so what Peter Fonagy came around to saying is there's this phenomenon called reflective function. And what that means is that a child comes to their parent and says, why do bullies in school beat me up? Why is the teacher such a jerk? Why is our president doing what he's doing? And a good parent is always there to help the child understand themselves in relation to other people, in relation to the world around them, and the systems around them, and help interpret that in some way. So if you don't have parents that are doing that, if you have parents that feed and water you, but are not really present themselves, and giving the child 15 minutes of pure time a day to help understand what's going on and to praise them and love them, care for them, then the system becomes segregated. And so there's distinction of parts. And so there's no cohesion that develops, and there's an emptiness. And usually when the child will feel sort of unloved in some way. Now that's an interesting word, unloved, because in many ways PTSD was the wrong paradigm. Because when we got more and more data about adverse childhood experiences, what we realized is that most of the things that happen to kids is not PTSD. But if you remember from the ACE study, 17,000 people, that 65% of the sample had severe adverse childhood experiences. It was endemic in the group. It was huge. And assault, witnessing assault, actual sexual abuse, physical abuse, and so on. When an adverse childhood experience develops, then there's a splitting, and the person gets stuck at sort of T-1. And some part of them remains sort of stuck here, which is where dissociation begins to occur, and frozen at T-1, and then they get bigger and older. And so the system sort of splits. And so a person will say, I feel like I'm a bad person, but I know I'm good. I feel stupid, but I know I'm smart. I feel defective and damaged. And the result of feeling bad about oneself is you become obsessed with perfection and performance. And so you become what we call a sense of otherization. Otherization implies that much of what you do is to please others and not disappoint them. And so you become reactive. And you become a good capitalist. Because you want to be successful, you want to get high up in the hierarchy, you want to make a lot of money, and you want to buy a BMW. Right? Isn't that what we all want? Okay. And if that happens, then we're a human doing, not a human being. And so our socialization is creating human doings. And it's antithetical to creating human beings. And so the new Mindfulness Revolution, I think, is really oriented towards helping human beings begin to recognize that they're on the wrong path if they're trying to be human doings. But what it is that our clients they hate themselves, and they're trying to undo that by performing better. And that's what we're dealing with every day, with every client. And so the schemas, those ingrained ways. Lori and I went to hear Jeffrey Young do a week-long workshop on schema therapy. And he started out by saying, I worked with Beck in Beck's lab for years, and I became a specialist in cognitive therapy. And what I realized was that cognitive therapy doesn't work if the client has a personality disorder. And that what we need is something more in the deep structure. And so I created schema therapy. Now I thought to myself, holy cow, is he really saying what I think he's saying? Which is that I know every one of my clients has a personality disorder. And here I am, like I've been reading Beck's book for years, trying to do cognitive therapy with him, and it doesn't work very well, and I assume that I'm a crappy therapist. But maybe it's that cognitive therapy is necessary but not sufficient. Have you ever had that effect? Like, you read the book and it doesn't work for you? Anyway, the point being that it's in the deep structure where a person feels defective and damaged in some way. And so what is the way of taking somebody who hates themselves and transforming that schema and building a self that is coherent and cohesive? And so I think that the real reason why a person has an addiction is that they're in distress. That they won't be able to tell you what their distress is. They'll just sort of, in some inchoate way, say, I just feel empty, alone, scared all the time. And that I need to escape that. And I think that removing the substance, i.e. sobriety, is not the solution. Because if you remove the substance, then you leave them with chronic emptiness and chronic aloneness and chronic misery. So you give them 12-step programs where they can have a community, but I would suggest that although that's necessary, it's not sufficient, because they don't have the structural capacity to connect with other human beings. And 12-step programs is not going to do that. It's going to be like a Band-Aid, but not give them the structural capacity. So the real goal, to me, is seeding the development of the real self, which sounds a lot like Masterson, Cove, Winnicott, and being able to teach them how to connect. But remember, when you were 9, 10, 11, 12, 13, 14 years old, a lot of things were going on in your life. You were interacting with kids at school, you were interacting with teachers, you were out in the playground learning sports, a lot of things were going on. Now, the kids that I treat, who are now adults, were alone. They were disconnected. Because of the trauma, they felt different chronically. I'll do some self-disclosure. When I was 12, my dad suddenly died. And I remember the feeling, which was, I felt embarrassed because I felt different than all my friends. And I felt like I was sort of walking on air. That was the only way to describe it. I would walk around and my feet were on the ground. And I went away. I wasn't able to cry at my dad's funeral. My mom, kind of shipped me off to prep school. And I lost my home, I lost my friends, I lost my family. And, I was put in this weird prep school. And I remember that I just sort of went away. I became constricted. I put up walls around me. And I couldn't get close anymore. And whoever I was with, it was sort of like they were different than me. They weren't of my tribe anymore because I had this event occur in my life that made me different than everybody else. Okay? So, having experienced that myself, I understood dissociation, and I understood disconnection, and I understood what happens, which was, when I finally got to college, I walled myself off and spent hundreds of hours in the monkey labs. And so we had rhesus monkeys that I worked with. And so I would be in the monkey labs till 2 or 3 in the morning. And, I became sort of brilliant, with monkey stuff. But with human beings, I began to getting further and further away. Okay? Now, that's really good if you want to become a human doing. Because I got into Johns Hopkins, I got OAs, read a lot of books. It was good stuff. But the cost of that was far, far too great. Okay? So my point is that you become scared all the time, you escape, and for me, I went to workaholism because it was a way of binding my fear and anxiety and dealing with my aloneness. Okay? So if you took my work away from me, I would feel like I was thrown out of an airplane without a parachute. And I think that's what we do with our clients. We throw them out of airplanes without parachutes because they're using the addiction as a way of binding their anxiety, binding their fear. It is a distorted survival strategy. They use it to survive. It's helped them through some difficult times. In my life, when I've had some really difficult things happen, I go into my cocoon. My cocoon is I just work, 20 hours a day. And it works all the time. If I do that for, a couple months, I'll come out of my cocoon and I feel strong, But I haven't dealt with any crap, I just worked. Okay. And so it's a form of dissociation. So what's my point? My point is that we need to look at the addiction not as we're a success if we create sobriety or control of out-of-control behavior. But our success is understanding the function of the symptom, understand what it does for that person, and then help them meet those things directly through changes in what they do. And so I call those structural capacities. When you're 2, 3, 4, 5, 6, 7, 8, 9, 10, you learn certain things. Your brain is still developing, and you learn how to operate in the world. And what I'm doing with my clients, I'm learning that they don't know how to be in the world. One of my first anorexics that I worked with at Castlewood was, I did incredible work. I was so proud of myself. This was a very severe dying anorexic. And at the end of the treatment, I had done family work, I had done individual work, I had done refeeding work. It was textbook. And she was treated successfully. She was no longer depressed. Yay me. And about a month after she left the program, I went to visit her. And in her apartment, she had beer cans, and food wrappers up the gazoo. She hadn't left the room. And she said to me, Mark, she said, I don't know how to live in the world. I said, what do you mean? She said, well, I don't know how to pay my bills. I don't know how to be with people. I don't know how to be in the world. And I said, oh, I can teach you how to pay your bills. And she said to me, Mark, you don't get it, and you never will. Okay? And so, I listen to my clients, and boy, was that a true statement. So, I would talk with a lot of recovered individuals because, a lot of my staff had recovered, and I felt like they knew stuff that I will never know from textbooks. And so I'd ask them and try to get this. And what she was saying to me is, I don't know how to live in the world. Okay? And that entails I don't know how to be with people. I don't know how to connect with people. I don't know how to pay my bills. I don't know how to solve problems. They don't have the structural capacities of things that you learn at age 5, 6, 7, 8, 9, 10. So I read this wonderful book by Stanley Greenspan. And what he says is that all therapists should be trained to be child therapists. Because what we're dealing with in adults is child deficits. And that was brilliant. So I started looking, he calls these structural capacities that the child learns at different developmental stages. And it's like, oh yeah, this is it. And I began to see that the clients had these kinds of structural incapacities. And so a lot of them were things that I couldn't see in my 15-minute hour. I started working with life coaches. And the life coach, I said, tell me a little bit about what happened with my client this week. Well, we went out, and she was walking like this and staring at the ground. And we went, and I had her sit up straight, had her hold her body up, had her open up her eyes, had a smile on her face, had her walk up to people and say, hi, and, be able to have body language and affect kind of gestures that say, I want to know you, I want to meet you. And we don't really, so much of what goes on between people is affectively attuned, right? And so we're sending out messages that say, please stay away. And so when they date, that they're not able to find partners, when they're not able to make friends, and they're miserable and depressed because they have these looks on their face, I'm depressed, I'm miserable, stay away from me, right? But I would never see that in my office because, what I'm getting in my office is not a representation. So what we need is an assessment of that. So, in summary, what I'm trying to say is that if you begin to look at from a different lens, the lens of psychiatry is the wrong lens because that's the disease model, an illness model, take a drug, get better. That's the wrong lens. We all know that. What is the right lens? It's a developmental model of studying the trajectory of events that have occurred that have contributed to this outcome and finding out what the function of the addiction and the addictive behavior has become and working in the deep structures to be able to change those. And what we're going to try to do today is we're going to show you, given that conceptual model, what do we actually do in the room? So today is really oriented towards tools for work for clinicians. And what do you actually do with the patient? So the way I would translate that is, let's say the person binged and purged last night. I'm going to say to them something like, okay, so in a relapse prevention model, we're going to look at the events that have led up to binging and purging. That's a good thing to do. We're going to understand the triggers, the high-risk situation, the affect or lack of affect, the ability to avoid affect, and all that good kind of stuff. And then we're going to take that behavior and we're going to follow it back and understand, when did the person learn that binging was the solution to some of their life problems? And so in this model, it's sort of akin to hypnosis, where in hypnosis you do what's called affect bridges and somatic bridges. And if you take the affect and the somatic, and at some point the person stumbled onto binging as a solution and to an old problem. And that old problem is usually around an ACE event. ACE being an event in their life that was overwhelming, but probably not a full PTSD. Could be neglect or it could be abuse. And that it became a solution to that dilemma. And that is going to be a step. As we work with that, we will do trauma work, which I'll now define. And that trauma work is a necessary step in the treatment of addicts, but it's not sufficient. So what we discovered is, running a trauma unit, we did really good work, and it was necessary but not sufficient. So what I want to do before the day is over is I want to give you all the necessary and sufficient elements of working with trauma and addiction. Okay, so let's look at it in a more structural way. So the addictive behavior rises not just simply as a pleasure from the nucleus accumbens, but to self-soothe and self-regulate. It's a form of affect regulation. And sometimes a form of affect neglect. So I don't know what I feel, I just feel crappy and I need to escape in some way. So learning to identify feelings and use them as signal states is a necessary step in treatment. And sometimes I feel so terrified and out of control that sometimes I use the addiction to calm myself down. So when I feel depressed, the addiction brings me up. When I feel up, the addiction brings me down. So it's both ends. And you treat the hypoarousal symptoms of depression. Yeah, it's interesting about depression. What causes depression? Everybody knows it has to do with medication and brain changes, and it's a disease, right? Wrong. Depression is the outcome of having too many ACEs. I'm going to show you the data in just a little bit. But if you have trauma, depression can be a natural result of that. There's this wonderful study coming out of Boston where they look at vets that do not develop PTSD, who are frontline vets, and they follow them for a 5-year period. So these are, let's say you have 100 soldiers in the same war, and so let's say 5 of them develop PTSD. Let's look at the 95 who don't develop PTSD and see what happens. And what you find is that every year the rate of depression increases, so that at the end of 5 years, 80% of the sample become severely depressed. Now that is remarkable. Why? Because everybody knows we want to treat PTSD, and it's the cost of treating PTSD is worse than the cost of the war. The war cost $1 million a day per soldier, and the cost of treating PTSD, I guess, is more than that. But if 80% of the ones who don't develop PTSD are going to get severely depressed after 5 years, can you imagine the cost of treatment of veterans? So let's not let anybody know that, okay? Keep that in this room. You're all looking at me like I'm nuts. Yes, I am. It's amazing because trauma over a long period of time has that effect. And so what happens, yes, it does change the biochemistry. Your serotonin, your dopamine, your noradrenaline, your glutamate, your GABA systems, all of those are changing as a result of trauma. So it is biochemical, but events postnatally change the brain. So understanding the disease model does not mean genetics or biochemistry in just a restrictive way. It means that these events in your life can have dramatic effects. And the treatment, of course, would be to do the work around the trauma. So you have eating disorders. You have compulsive sexual behavior. You have self-injury in varieties of ways, and substance abuse. And what's remarkable about treating all of them in the same community is that there are so many things that are similar among the groups, that they learn so much from one another. And yet there are some things that are remarkably different. And that's also a great important thing. But when we look around the room, yesterday we asked the clients, how many of you have felt alone all of your life? And every single person raised their hand. Okay? So there's something really important about the similarities as well as the differences. So in this new model, just to try to define it, it's a psychology-based model rather than a psychiatry-based model. It says develop, and a guy like if you have tried to follow it, there's a journal called Developmental Psychopathology, which I get every month. It's an awesome journal. And Cuccetti is the editor of that. And there's just an incredible stuff that's come out of that field. And developmental deviation of an ontogenetic process, failure of adaptations, pattern of adaptation reflecting the totality of the developmental context at that point. Maladaptation can be a result of different developmental pathways which are probabilistically related to disturbance. Individuals beginning in a similar path may diverge. Okay. Now, when you use big words like that, people say you're really smart. What he's really saying is that you want to look at the developmental pathway that results in a disorder, and that pathway can diverge. Like, for example, if you are neglected at home, but you have a teacher who really loves you, or a grandmother who's there for you, that can change the whole pathway. So you can't say cause and effect, because a lot of divergences can occur, so you're not doomed if you have certain things that have happened. And certain things like seeing a therapist can make one hell of a difference, as we all know. Now, we had developed a 360 item way of looking at structural deficits and skills. And then we developed a system to be able to graph it. And so we could look at what would be normative and what our clients had. So it might be something like self-care skills, health and wellness, emotional and intimacy skills, goal-setting skills, social skills, so on. And then as part of our assessment, what we wanted to know was not only the structural deficits, but the skill deficits. So if you don't know how to use your feelings as a signal state for creative action, what happens is you'll go home and you have all this new insight into yourself and new feeling state. You know, for me personally, if I am distressed, my brain focuses on that distress and it perseverates on trying to think of plan A, plan B, and plan C to do something about that. And then I implement plan A, plan B, and plan C and try to be able to improve it. And I take that for granted, but with the eating disorder population, they weren't able to do that. They aren't able to somehow enact and problem solve. They didn't have that structural capacity. So I had to find a way to assess that and then say, what are we going to be able to do with that skill? So like DBT is a great modality for beginning to look at problem solving and Linehan, was one of the early people to really identify some of that borderline personality disorder is really a structural skill deficit disorder. And there's lots and lots of new DBT stuff that really is good for this kind of thing. But there's nothing better than a life coach working with them on the streets, basically teaching them, because we can learn anything, but we have to sort of see someone do it in order to be able to learn it in some way. All right. Now, Alan Schwartz wrote this wonderful quote. He says, "The child's first relationship is a template that molds the individual's capacity to enter into all emotional relationships. And development represents sequential, mutually driven infant caregiver processes. Affect is what's transacted within the individual." So I think most of you know these data, but a woman named Babe did this beautiful work where she videotaped the mother and the child and stopped the videotape. And so they did 1 second intervals, and the mother would smile, and 1 second later the baby smiled. The mother would get scared, and 1 second later the baby would get scared. And what you could see on the videotapes is that the mother's central nervous system is somehow hardwired into the child's central nervous system. And the mirror neurons are the ways to be able to understand that. So that's rather fascinating, because if you have a mother who has unfinished business, let's say the mother is a Holocaust survivor, or the mother is the daughter of a Holocaust survivor, and you're scared all the time, that child is going to be scared all the time. And so we have the intergenerational transmission of trauma via mirror neurons. Well, that's breathtaking, right? So when the client comes in, you say, "So why are you depressed?" They're going to say, "Oh, because my mom is a Holocaust survivor, a daughter of a Holocaust survivor, and her mirror neurons kind of fired mine up, and the result of that, no, it's not going to happen." She's going, "I don't know, So as you bring, I like to do is I see a client, I like to bring their mother in, their father in, their brother, the sister, the aunt, the uncle, anybody will talk to me, the next door neighbor. And I want to put pieces together, because as I'm trying to get this narrative, what I'm really trying to do is begin to develop a narrative, because mostly the client's going to say, "I don't know," to a lot of things. And I want to put the pieces of the puzzle together, and I want to know that the grandmother was a Holocaust survivor. I want to know that they're first-generation immigrants. I want to know that their parents were unable to use affect or emotions, and so on. All that is going to be instructive. Now, one other piece happened, particularly when we're working with eating disorder clients, which was what we discovered was that there's a new kind of trauma, and it's called overindulgence. And I emphasize this because it's not in the books much, but what happens is, like Cove said, it's feeding without nutrition. And what happens is that the parents get preoccupied with work and themselves, and at the same time are over-focused on the children. And so they're Phi Beta Kappa parents, and they shower the children with material goods to make up for the fact that they can't be with them as much as they like. And they emphasize you're only as good as your last accomplishment. So this new generation of young people that we're seeing is different than any other population I've ever worked with. And particularly the ones who are hardwired into their computers or games every day as a babysitter, because there's something really different happening inside their brain. And in this overindulgence with overcontrol, in the research data that's coming out, these kids look as they grow up a lot like kids who were locked in closets and burnt with cigarettes. The effects long term are really severe. But in many ways it's worse, because when you're locked in closets and burnt with cigarettes, you know that terrible things were done to you. But they feel guilty for being so screwed up because they had the world's best Phi Beta Kappa parents. And it's really confusing to them. And so as you study it, what you see is that there are over-control that goes with that, like constraining verbal expressions. You change the subject whenever a child says something to say, interrupt the child, invalidating feelings. If you really cared for me, you wouldn't do things that cause me to worry. Acts disappointed when the child misbehaves. Tells the child we get embarrassed when she doesn't meet our expectations. all the things good parents do, right? But it turns out that this overcontrol with overindulgence seems to be very, very traumatic to the child. Well, we call that spoiling. But it took developmental psychology to try to delineate what we meant by spoiling. And it's a flavor of overcontrol and overindulgence in some way. And that seemed to be one of the trajectories for a lot of the eating disorder patients we were seeing. So it's important to pull those data out and be able to let people see that it's a different kind of trauma. Because separation and individuation is real. And learning to individuate, operate the world, explore your environment is really critical, and overindulgence interferes with that. Now, I mentioned the ACE study. 1 in 4 exposed to 2 categories, 1 in 16 were exposed to 4 categories. 66% of the women experienced abuse, violence, family strife in childhood. This changes everything. It does. It really changes everything. Because what it's saying is that severe trauma is endemic, and that in all of our clients, we're having to do this kind of work. And look at this. The higher the ACE score, the more alcoholism. So this is cause and effect. So, when I say that a Sc.D program needs to deal with trauma, it's pretty obvious. One of my great heroes is a guy named Alice Roth, and he was funded for 30 years by NIH to follow a cohort of 270 children before they were born. And they followed the children, their mothers, their sisters, brothers, for 30 years. And he published his book after 30 years of longitudinal study. And I think it's probably the most important book in the field, although it's one of those ones that people don't read very much. And these were children of poverty that had a high rate of disorganized attachment. And what he found was that there are multiple pathways to similar outcomes. So, anorexia probably has multiple pathways. Chemical dependency has multiple pathways. And that the key feature was a fragmented sense of self, and disorganized attachment results in dissociation. So at Castlewood, the first 100 patients that we had there with eating disorders, I did the adult attachment interview. And what I found was there were no patients that we had that had secure attachment. And 90% had disorganized attachment. So I said, if you want to treat eating disorders, don't focus on the food. Focus on disorganized attachment. The food it's necessary but not sufficient. But what we need to do is work on the disorganized attachment. And so became very, very busy in trying to understand this. And so Lee and Lori and I have teamed up, and we've been having years of study of this attachment system and disorganized attachment in particular. Okay, so what I'm then saying is that the next step in understanding PTSD trauma is complex trauma. Complex trauma came out a couple years ago because most of our clients didn't have full PTSD, but they had many of the ingredients of it. So in the criteria for developmental trauma, look at the components of it. This was the DSM proposal. Intense preoccupation with safety of the caregiver. So instead of the caregiver taking care of the child's taking care of the caregiver. That's preoccupied attachment. Persistent negative sense of self, self-hatred. Extreme negative sense of self, self-loathing, helplessness. Reactive physical and verbal aggression towards peers, caregivers, and others. Either turning it to self or others. Inappropriate attempts to get intimate contact. Impaired capacity to regulate empathetic arousal. Now, if I said to you, how do you treat opiate addiction? And the answer is 1 through 6. How many programs do you think are directing their interventions to 1 through 6? It's getting somebody sober. I know how to get somebody sober. Lock them in a treatment center for 30 days. where they can't get any drugs, and they'll become sober, and your success rate will be 100%, right? Great. Okay, don't let them out. Don't let them go on AA meetings without supervision, because you'll be in trouble. But is that effective treatment? I ask myself. Okay? And I'm not like pointing a finger, because, in our eating disorder center, we sat people down at the table and we said, eat the damn food. And they would eat the food and they'd get refed, and we had treatment effectiveness. And it's necessary but not sufficient. If you don't have proper nutrition, if you're not sober, you can't do psychotherapy. Don't try doing psychotherapy with somebody who's drinking every week. It doesn't work, right? We all know that. So sobriety is the first step in treatment, but we have never delineated all the other components that are absolutely critical. Now, if you define these as critical, if I go out to 100 therapists and I say, how do you see the development of the real self? I don't think we're going to get very good answers. And yet, we should. We should have a cookbook of how to facilitate the development of the real self. Again, Lee's going to tell you about that this afternoon. Okay, so Dick Schwartz came around. Lori's going to be talking about that. And we love Dick. And what Lori says is that when we learned internal family systems, it was like doing surgery with a laser rather than with a scalpel. It was tighter, sharper, and less, kind of bleeding. And it was more effective. So we learned EMDR, we learned hypnosis, we learned internal family systems, but the internal family systems seem to be the most effective tool. So we tend to use that more, but we tend to use all of them at different times. And what Dick said is that there's this concept of burdens, which is that all human beings, not just the ones that have ACEs, have these burdens that we carry with us. And it's much easier to think of these burdens as beliefs, feelings, or energetic residue of events and experiences that overwhelm the internal and the external accessible resources of the organism at the time. So trauma becomes any event that you cannot consolidate into long-term memory. Your hippocampus won't consolidate it. It goes down to your amygdala and hangs out as state-dependent memory. And it's a residue. It just, it darkens everything. And everything is seen through those lenses. And so what we're trying to do is unburden folks. That becomes what we do with all therapy, rather than just sort of some therapy. And it's a much more humanistic concept, because trauma has too many associations with it. And the real trick of doing trauma work is being able to work with the dissociative features. So if behind trauma is disorganized attachment, behind disorganized attachment is depression and anxiety, and behind dissociation, behind trauma, disorganized attachment, depression, and anxiety is a dissociative feature, then the key aspect is that the more we understand about dissociative phenomena, the more effective we're going to be. The reason why a person feels like they're bad and knows they're good is because of dissociation. We can know things, see things, and feel things. And so Nicholas is going to be talking about the Basque model: behavior, affect, sensation, and knowledge. They all can become dissociated, so you can know something and not know it at the same time. The real feature then is trying to be able to, if the person feels damaged, defective, and bad, and the person hates themselves, then what Dick would say is that we need to facilitate self-healing. And so the therapist becomes a catalyst to self-healing. And so when we talk about internal family systems this afternoon, what we're going to be talking about is how the therapist can facilitate self-healing. And the self begins to communicate with these parts of self that are damaged, feel damaged, and begin to repair it in some ways, because the self knows exactly what it is that they need to hear. And in addition to that, one has to begin to repair the disorganized attachment. And so what happens is that in the disorganized attachment, there's a simultaneous activation of wanting to get close and wanting to distance. Simultaneous activation. So when you meet somebody you really like, the attachment system gets activated and you move towards affiliative behavior. If you move towards somebody who you dislike, the shields go up and you disengage. And this is an actual system in the brain. And so in the contemporary understanding of attachment, what we've come to realize is that all of us have a system in our brain which is a natural anxiolytic. And what is that system? It's the attachment system. How do we know that? Because when a baby begins to cry, the mama picks up the baby and rocks the baby. And when she does, the baby stops crying. Okay? So the attachment system is the natural anxiolytic. When a child is scared, the father comes and holds the child and soothes the child and comforts the child, and the child is comforted and calms down. Well, what happens if the person comforting the child is the source of danger? Okay. It would be simultaneous to feeding a rat and shocking him at the same time. What happens if you do that? If you feed a rat and shock him at the same time? You got one incredibly crazy rat. Okay? And they do really crazy things. So the paradigm that we're seeing in mental health is that the person who comforts you is also the source of danger and fear. And so it really screws up the system. So what are you going to do to stay safe and soothe yourself? Drink, drugs, sex, restrict, right? Because in your mind, you're not going to say, Daddy molests me at night, he's dangerous, stay away from him. You're going to say, I love Daddy. Daddy loves me. I've been a bad little girl. That's why Daddy hurts me. Okay? And that's what every child thinks in terms of primary process thinking. Well, that's going to get hardwired into the brain. And so you can just imagine how confusing that could be to a human being. Because the person that's tucking them in is also the person who's raping them. Right? So that's what we're dealing with so often, are these structural, confusing kinds of things. What else could be other than dissociation? So in order to make sense of that, Daddy loves me, Daddy hates me, Mommy loves me, Mommy doesn't protect me, is you have these systems that become implanted into the brain that are polarized. And these polarized self-systems is good kid, good mom, good dad, bad dad. And that's all the, the good enough mother stuff that Winnicott used to talk about. And all of that results in these dissociated systems. And so the real cure for addiction is moving towards secure attachment. And the real cure for addiction is beginning to integrate these self systems. Dan Siegel, who I think most of us consider one of our heroes, he just says the same thing over and over again. The solution is integration. Integration of brain systems, integration of the mind, integration. And when you have these contradictory, polarized systems, you're at war with yourself all the time. The client will come in and I'll say, what do you want? What do you want? And, they want one thing and they want the opposite thing. They feel one way, they feel the opposite way. And they're just fighting one another, all these polarized internal systems, and they're in civil war, strangling one another. And if we don't begin to get these internalized systems delineated and begin to figure out how to live in the same body. So Dick Schwartz's real contribution was to understand that we have these parts inside of us that are at war with one another, and that the real solution is doing, some kind of family therapy where we're able to integrate them. So the framework for treatment, you need to have an environmental structure sufficient to reduce the likelihood of relapse and trauma. 2, you need to use psychotropic medication to reduce the severity of symptoms. You need to develop non-addictive skills for anxiety management, problem solving, cognitive restructuring, emotional regulation, distress tolerance, and self-defense. So yeah, you need to know DBT. You need to have a damn good psychiatrist. And you need to be able to assess the whole family system and not return them to the dysfunctional family system. Okay? ABC. All these things are necessary, but none of them sufficient. It's just difficult work. And then the basic model that we started with was called abreaction. Abreaction was vivid reliving of the traumatic experience. And that was a bit re-victimizing, because anybody re-experiencing trauma, it just feels like you're being traumatized again. So the second model was exposure therapy. Exposure therapy was going back and exposing somebody to the trauma over and over and over again until it, some sort of tolerance develops and it becomes less activating. And all those were effective therapies, but had their problems. We first developed a model called reliving, revising, and revisiting. It was borrowed from the Gouldings. And the idea of it was a person needed to relive the trauma with one foot in the past and one foot in the present. And so they have the injured part of self re-experiencing the trauma. The injured part of self re-experiencing the trauma. Co-conscious with the self who's wise and who is compassionate. And we develop a relationship between self and injured part of self. And so they internally develop some sort of secure attachment. And we actually work to develop that secure attachment because they have to learn to live in the same body, and oftentimes they hate each other. But if we get the parts that hate each other to step back and get the real self in and develop that relationship. And then the injured part begins to feel and talk about what happened to them. And that's called primary process thinking. Primary process means what it was like for the injured part at the time and the way they processed it. So, Daddy molested me because I lost my hair beret. Well, it's not really right. That's the way a child thinks. So we want to know exactly how the child processed the event at the time. And this time we have reflective function. Reflective function here is that the self can begin to reprocess the event from the adult point of view. And if they get stuck, the therapist can lend some of their self to the self to facilitate that process. And that is called witnessing. And witnessing, from a compassion point of view, is incredibly healing. Pat Riesick would call that cognitive restructuring. The real gift of doing trauma work is in the cognitive restructuring. The new EMDR, it takes all Francine Shapiro's brilliance, but adds to it, Laura Parnell does this beautiful, nice work in teaching people how to do the cognitive restructuring around the EMDR, the new EMDR. And she takes everything from affect accelerated therapy, internal family systems therapy, all the new stuff that has come out, and incorporates it into her EMDR model. And it's really quite beautiful. But it's not something you can just do. It takes tremendous skill to be able to blend in the cognitive restructuring piece and this self-healing piece that's so necessary. And what you're doing is you're doing top-down kind of changes in the brain. The brain, the first 20 years of life is differentiating. That's bottom-up kind of stuff. And all this stuff is structurally written into the brain. And so EMDR and some of these new affect accelerated therapies are top down, and we're changing brain structures. It's so interesting, in the trauma work, they took a group of people who had severe trauma, and one group received exposure-based therapy, sort of NFO type, and the second group received exposure therapy plus attachment work, and they followed it in the brain. And the people who got exposure therapy got a lot better, but you could look in the brain, and it did not change things in the amygdala. The amygdala on the fMRIs looked the same. But if you did attachment work plus trauma work, you could see it moving up to the hippocampus and consolidating the hippocampus in long-term memory. And so in that process, what you see is that the exposure work is necessary but not sufficient, and that the attachment work is an essential component of this process. China Fisher is here in San Francisco, and she used to work at Bessel in Boston, and she's a brilliant one, and she's written a couple great books. And what she says is that therapeutic contracting is complicated in trauma work because of the issues of power, control, and so on. And that part of the work that gets complex is that you have to really know that you can't do harm. And so there's been a tremendous emphasis on teaching people grounding, containment, and etc. So, like I have a client now who's chronically hoarding, bipolar, out of control, won't take her medication religiously, and compulsively buying things and isolating herself. And she has lots of trauma. And we've had her in therapy for a long time. And she keeps saying, everyone else is getting to do the work. Why can't we do the work? And I say, we can't do the work until there's proper grounding and containment. And so you earn the right to do the depth work by beginning to take your medication, by stopping the hoarding, by working with a life coach and getting 3 friends, by starting dating life. I want stabilization. And if you stabilize, then we'll be willing to do the depth work. And it works really well because it gives them a great incentive that, what I'd like to see in the next 30 days is we'll help you begin to get containment and structure in your life. And if you do that, then we'll do the work that needs to be done. Now, unfortunately, in an outpatient setting, this can take years. It's like 2 steps forward and 3 steps backwards. So the real power of a program like we're setting up is, because of that frustration, is to do a year's worth of work in a month. And you can do that, in an intensive program. So, our average length of stay is about 3 months. And we're able to get people 5 days a week, 6 hours a day, 3 sessions a week with us, 1 session with a psychiatrist, 1 session with a dietitian. And, that intensive format allows us to be able to do quick stabilization plus, a therapeutic community. There's nothing like a therapeutic community. In a therapeutic community, people are helping each other 24/7. And so they're learning secure attachment. They're learning to turn to other people as a resource. So when you want to binge, you go to the person in the next room and you're able to say, look, I want to binge, could you talk to me? And so you learn to turn towards other people rather than being so isolative and alone, which then, is part of the thing. So if you have a group therapy, it works that way. If you have a therapeutic community, it works that way. But it's very, very hard to work with trauma if you don't have some sort of commitment towards stabilization and a therapeutic community to work from in some way. All right, Janice also says that common mistakes made by working with self-destructiveness. And the number 2, not understanding a survivor's need to avoid relying on others. We tell them to call somebody, to call the hotline, to turn to their spouse. But what we all know is that the best way to deal with changing a habit is to have a friend to do it with. And you make that commitment to your friend and you work with your friend in that kind of a way. But since they're alone and unable to. So there's a book that Harville Hendricks and his wife Helen wrote called Receiving Love. It's just a great book. And in that book, it talks about people's blocks to receiving love and the inability to turn to others as a resource, which is part of secure attachment. And so what we're doing is pounding that into their heads, that the importance of having, it takes a village. Addicts do not recover alone. It just doesn't happen. It takes a village. So the 12-step programs are so good at doing that. So we oblige people to be in 12-step programs. We oblige them to be able to get stabilized. And then we're going to begin to do this depth work we're talking about. And going to begin to look at what she calls here the bystander phenomena. And the bystander phenomena is that most addicts are far more angry at the mother for not protecting them when the father's the abuser. And it's easy to be angry at your abuser, but it's really hard to be angry at the bystander. Why is that? Why is it so hard to be angry at the bystander?
Seems like they're the safer parent.
Seems like they're the safer parent. It's ambivalent attachment. When you love somebody and hate them at the same time, it's really confusing. And what you have to assume is, my mother is the only one who loved me, and if you take that away from me, then nobody loved me. And the child part of self will feel terrified, like there's nobody to protect me, I'm going to die any minute. So if you start saying bad things about their mom, if the dad's the abuser, you oftentimes leave therapy. So what do you do about that? Okay. This is really critical. It actually is one more critical feature of the therapy. You cannot work on the bystander. The bystander said, why didn't mom protect you? The answer is she couldn't. Okay? Why don't you stop drinking? I can't. Okay? So the interject of the bystander, she couldn't, I can't, is what gets implanted into the brain. It makes sense to the person. Mom couldn't, I can't. Okay? If you have to say, well, mom could have stopped this, then I can stop drinking. So you have to change that in the person's brain. But to be able to do that, one critical feature, which is that before you can do that work, there needs to be an internal relationship with self to the injured part. And that's called repairing. So in our model probably could best be described as a repairing paradigm. Because what we're doing is we're asking, as we expose the real self, we are catalyzing a process that the real self can begin to repair the injured part of self. Now, what does that look like? In some ways it's soul work. All the emphasis in Northern California for soul work, is really where it's at. Because in soul work, you go to the top of the mountain and you have a relationship with yourself. And there has to be an I before you can have a we. And so the real soul work is learning to be alone and having some peace and comfort in being alone, which hits the preoccupied of the attachment, and meditating and finding people who are like you and being able to nurture and love oneself and become a human being rather than a human doing. And not feel like you have to be perfectionistic and great at everything, but to enjoy the process of learning and growing. So, I always, with my patients, say, what's the meaning of life? And they look at me with these big eyes, right? Or like I'll go out with my friends and I'll say, have you ever thought about what's the meaning of your life? And they'll look at me and they'll say, I thought we were just having lunch, Mark. And, so I went out and I started buying books on, what is the meaning of life? And reading on, there's a whole human history of people searching for meaning and struggling with what is the meaning of life. But in our culture, it does not seem to happen much. Organized religions don't talk about what is the meaning of life very clearly. So, to me, that spiritual side, has always been at the very key of 12-step work. Although, it's put in a language that, for most of the clients, they don't quite get. But in a spiritual side, what we're trying to look at is that intimacy is not just with oneself, not just with our romantic partner, just with friends, but intimacy is a much wider kind of thing of being connected to all life. And the Buddhist traditions moving into psychotherapy are incredibly facilitating. So the Buddhist recovery is something we really strongly emphasize because it moves one step in addition to the 12 steps of beginning to add that Buddhist idea of getting in touch with self and life around us. So reparenting is beginning to how you want to teach your child in an optimal way how to really live in the world and live with themselves in a deeper sort of way. And so the book that we're going to be talking about this afternoon is Dan Brown and David Elliott's book called Attachment Disturbances in Adulthood. Is that what it is? Yeah. If you haven't read that book, it is breathtaking. I mean, knock you off your feet, breathtaking. And there's so much in it. But one of the things that Dan does, and David, so beautifully, is they talk about sort of the, sort of a Maslowian kind of model of self-actualization. And that, there's this first step of learning how to attach to self, then learning how to attach to people. And then, as you evolve, learning how to begin to attach in a much wider way to the world around you and to the environment. And of course, that's sort of the basic model of parenting that all of us would love to have. And so as you begin to define a reparenting model, it's an evolutionary. The purpose of life for me is growth. I love learning. I love growing. The nature of all cells is to differentiate. And one of the best ways to learn is by making mistakes. And so to reframe mistakes as not you're bad and terrifying, but mistakes as being a great opportunity to learn and grow. So, now, the key to all psychotherapy is understanding resistance. And so, as you begin to take people closer to health, to secure attachment, and the truth, what we're looking at is beginning to look at the blocks. So how am I avoiding remembering? How am I avoiding feeling? How am I avoiding talking about it? How am I minimizing? How am I avoiding focusing on enjoying my life? Pleasure is something they don't understand. Playing is something they've never done. How am I avoiding noticing triggers that cause me to hurt myself? How am I still protecting my family? How am I avoiding being close to others? What secrets have I not discussed? How am I fighting my therapist? I have people write a page on each of these things. Now, the question I always ask is, what do you think is the biggest block in doing trauma work? What's the greatest resistance? Pick a number. Anybody? What secrets have I not yet discussed? That's common. but it's not the biggest. 2, am I avoiding feeling? A lot of them don't have a vocabulary to know how to feel. So you have to teach them like you teach children how to feel. But usually it's something blocking them from feeling. You have to move the roadblocks.
Denial.
Okay. Number 7.
You said so.
Oh.
7 is the ticket. Now, the reason 7 is the ticket is because the key feature of disorganized attachment is idealization. And the more somebody hurts you, the more you tend to idealize them. And so, idealization of the family, and when you start doing that, you get accused of blaming families. And so every time I have a family member come in, the first thing I look at is I look at them and I say, it's not your fault. Okay? And if you're feeling like you're coming here and you're going to get blamed, that's not what this is about. Okay? And if you feel guilty and you come here to defend yourself, we're not going to help the client. Because guilt and defensiveness goes together. So I first have to neutralize that natural feature. And all we want to do is we want to begin to look at the truth without rose-colored glasses. And so what we want to know is what happened to you, what you did as a result of what happened to you, how you pass that on to your children, and what you might have done differently. So what Lori always says is that the only scary parent is when you say, is there anything you wish you had done differently with your children? And they say no, that's a scary parent. Because every good parent knows that, hindsight 20/20 vision, they wish they had known then what they know now. And that's the nature of all growth. So the idea of this is not to blame your family, although there might be a stage where you need to get angry at your family. But the idea of that is you go through that temporarily until you can get to the other side and feel some sense of peace. Now, how do you feel peace with somebody who shot you with a gun and put you in a wheelchair? Well, we don't necessarily encourage forgiveness. What we encourage is what we call acceptance, which is hating somebody is much more trauma bonding than loving somebody. So hating just destroys the soul. So you've got to get to the other side of hating somebody and having some degree of acceptance to have inner peace. And so what we're looking for is that the person finds an inner peace that comes from working through the event and the hate and the anger that they feel towards others and towards themselves. So then, I guess I'll end with this, that if you want a cookbook, what it looks like is I always begin with cognitive reprocessing therapy. In cognitive reprocessing therapy, that's Pat Resick's model, where we're going to write a trauma narrative, an impact statement, how it affected your sense of yourself, others, and the world around you. An impact statement of looking at how it impacted self, your perception of self, others, and the world around you. That's an impact statement. You read it in group. Then I want to draw the trauma because I want the injured self represent what happened to them, and kids represent what happened to them better with drawings than with words. And then to share the trauma narrative and the drawing in group, and to get feedback so that they can compare their perception with other people's perception and use the group as a healing modality. Then begin to challenge cognitive distortions. We call these the ABC sheets, and looking at ways that the conclusions you made about safety, trust, power, control, esteem, and intimacy. Safety, trust, power, control, and intimacy. And how those schemas develop out of a trauma-based model. And so I don't feel safe with anybody. I don't trust men. I hate myself. I feel disempowered. And the only power I have is with sexual initiation and intimacy. people are dangerous. And we have to work around those core schema and see how they're trauma bonded and begin to reshape those core belief systems. Then some sort of desensitization through exposure or exposure techniques. And then we do EMDR because oftentimes the events, what Francine Shapiro says is that there are channels. And under every channel of trauma, there's another channel. And under every channel, there's another channel. So you can't really resolve a trauma by working on just the trauma. You have to look at the reservoirs and the channels underneath it that flow into that in some ways. Then we're going to move into psychodrama and other forms of expressive therapy, somatic work, anger work, because trauma is in the body and we have to do something to be able to get it out of the body and have the person basically unburdened. And then presentification and confrontation. A lot of people use presentification in different ways. I think you'll hear Nicholas talk about that this afternoon from one end. The way we use presentification is we do symbolic confrontations and have the person begin to have both the injured self and the adult self confront the perpetrator, or the perceived perpetrators, and direct their anger at the people who hurt them rather than towards themselves and others. So it's really anger work. And then explore the premorbid history and the function of the symptoms, the addiction, and understand how the addiction came as a distorted survival strategy. Understand most addictions have about 10 functions. If you hit 8 of them, the person will not get better. If you hit all 10 of them, they will. So you have to understand the 10 functions of the symptom, and then eventually acceptance and coming to terms with existential issues. So when I say trauma work is much more complicated than learning EMDR, what I'm saying is that what we have to do is understand the full gamut. And it's hard for one therapist to be this good at everything, because there's just so much to do, including the family work. So that's why I like working with the concept of a team. And then finally, what Dr. Masters used to say to me is that the carrot in all psychotherapy is the psychoeducation. And so there needs to be a component of relapse prevention. There needs to be a component of learning how to be able to have social skills. There needs to be a component of teaching people anger management. The DBT model is really good stuff in beginning to teach people, beginning to experience emotions in their body and tolerating those emotions without running out and being able to do something about it. And then the last slide, that integration, which is from Marty Horowitz, who's in San Francisco, another one of my great heroes, is the final result, which is rage at the source of the trauma, sadness over losses, discomfort over the realization of personal vulnerability, and so on down the line. But you want to begin to have a checklist. And the reason I give you these PowerPoint slides is because I use these all the time for myself. When I'm asking myself, where am I at in therapy? I want to be able to go through these lists myself and be able to say, where am I in the process of the therapy, and where am I in this reintegrating? And how do I know that the trauma has been treated effectively? And what are the criteria that I'm using in some ways? All right, questions? Any reflections?
Nicely done.
Thank you.
Really, really good.